Thank you, Kuresh. I think some of you may have heard this talk because a couple of years ago, Kuresh gave me the same talk. So here we go again. So I'm not just going to enumerate a list of visual fields from beginning to the end, but I'm just going to show you a couple of illustrated lessons with this, and we'll end up with a plan on how to interpret fields at the end. There are many reasons for doing visual fields. Topical localization is one and the most common, but we also use fields for, say, differential diagnosis. You have a swollen disc. If you see a central scotoma, it's optic neuritis. If you see an altitudinal field defect, more likely to be an AION. We can also monitor progression and recovery. For example, if you're treating someone with steroids, is it getting better? IIH patients or thyroid disease with compressive optic neuropathy, you're following up these patients with fields. So that's another reason to do fields. And lastly, and not the least important, is any patient with unexplained visual impairment deserves a visual field analysis. Okay, but today we'll stick to the familiar road of topical localization of fields as far as the visual pathway is concerned. Now, anatomically, if you look at the visual pathway, you have the rods and cones, the bipolar cells, and the ganglion, and the ganglion cell goes all the way to the LGB, and there you have another neuron which takes it over and goes on to the cortex. But as far as visual field localization is concerned, we can divide the visual field into certain other distinctive areas according to the way they produce field effects. So if you have a field effect corresponding to an outer retinal lesion, it may be of any particular pattern, but it will correspond to the fundus lesion that you are seeing. So some lesion in the upper temporal quadrant in the fundus will produce an inferonasal field effect of a similar shape that way. Secondly, you'll be familiar with, which is the inner retina, the ganglion cells and its axon, which forms the optic nerve and goes all the way, let's say, just stop short of the optic chiasm, and that's what we're looking at. The hallmark here would be the central scotoma, the centrocecal scotoma, and all the glaucoma defects that you know, because as you know, glaucoma is an optic neuropathy, however much the glaucoma specialists may disclaim that. Right. So area 3, all of you are very familiar with that, the optic chiasm and the classic bitemporal hemianopia. And lastly, everything behind the chiasm all the way to the occipital cortex always produces a contralateral homonymous hemianopia. Okay. The only difference being is if it's not a full homonymous hemianopia, you can divide it into different areas. For example, optic tract will produce incongruous defects, wherein the hemianopia will be more in one eye and less in the other eye. LGB produces sector anopias, the radiations produce quadrantic defects, and the occipital cortical lesions produce perfectly symmetrical, congruous, homonymous hemianopias. So let's take a look with 12 questions for you to field, pardon the pun, 6 illustrated lessons and 1 final plan, like the ring to tie them all together. Right, so what is this?
Bitemporal hemianopia.
Done. Bitemporal hemianopia. Okay, let's do the MRI. Okay, Kuresh says yes, we'll do the MRI. And what do you see here? You can see the pituitary adenoma there, which is chiasm. Okay, right, so this is easy, optic chiasm. Okay, this is a patient who had sudden onset of difficulty in seeing in his left eye. What kind of defect is this?
Quadrantonopia.
You think it's a quadrantic, but as you can see, it sort of goes up here as well.
Yeah.
Okay. So what is missing here in this field?
Second eye field.
The other eye. Okay. So when you do the other eye, you can actually see the exquisitely congruous nature of this defect pointing to an occipital cortical lesion. Otherwise, if it was just one eye, then this could even be something in the retina or some kind of an optic nerve issue or a ganglion cell layer thing. So always, message number 1 is perform visual fields of both eyes, irrespective of which eye is having the problem. Okay. Here, which eye is this? Field of which eye? Okay, easy to make out. Where is the blind spot? It's this side. So this will be the right field. Okay, yeah. So this is the right field. And before you ask me questions, let me tell you the left field was normal. Now you tell me what is this defect. So you can describe it. Yes, this is a superotemporal defect and it's spilling over a little bit on the top. Okay. But this could be a superotemporal quadrantic defect, which is why if you saw a similar defect in the opposite field, it automatically puts you in the radiations. Okay. But this doesn't, it's very localized, so it must be something along the optic nerve or inside the eye itself. Okay. So that's the blind spot should be there. And this is a chorioretinal scar. So this is an example of that region 1, outer retina, wherein the shape of the scar corresponds to the shape of the defect that you see. Okay. Okay, this is relatively simple. Someone from that side? What are these defects? Anyone? Yep. Which one is a centrocecal? Right or left? The left one is the right one. Okay. The right one is a centrocecal. You can see that connection to the blind spot. The left one is kind of walking towards the centrocecal, but our stop short is more like a central scotoma. That doesn't matter. Nomenclaturally slightly different. Where do they point to? Optic nerve. Yeah. This is following optic neuritis. This patient had postneuritic optic atrophy, and this is what his fields look like. Okay. This one? Otherwise fine. Okay. Superior altitudinal. Inferior altitudinal. Yeah. Inferior altitudinal. Little bit of a gap there, almost like some kind of a arcuate thing, but coming all the way up to the fixation. So prone to interpretation. But again, this is an optic nerve kind of a defect. This patient happened to be an ischemic optic neuropathy. You can see the upper disc pallor. Pallid edema is corresponding to the inferior field defect. Okay. Okay, so this is very clearly region 2. This one, for those of you who've seen this field, please hold on. Rashmin is racing to answer this question. Okay, anyone at the back? You've seen this before just now?
Same, bitemporal hemianopia.
Bitemporal hemianopia, says Kuresh. Thank you, Kuresh.
Yeah.
Okay, where are the blind spots?
One is present, the other one
Is also there, kind of.
Yeah.
Except that this is actually a
Flipped over.
Yep. So this is how you should look at it. Otherwise, if you just hold two fields randomly in front of you, you're prone to make this mistake and call it a bitemporal hemianopia. So this is a binasal hemianopia. Okay. Several reasons for binasal hemianopia. We won't go into that, but always the message here is this. Who put the fields in front of you as if you were the patient. So right field in front of your right eye and the patient's left field in front of your left eye. Then you start to interpret it. Okay. So this patient had a giant aneurysm, but aneurysm is not the major cause. A lot of the defects are in optic nerve diseases can produce this. Sometimes agenesis of the chiasm can also produce this as well. Okay. Okay. This is a patient already known, pituitary adenoma, saw him in 2013, and they used to come for follow-up saying, is the optic chiasm being compressed or not? And as you can see over the years, his vision has been maintaining well and everything is okay till 2023, and he was lost to follow-up in between. So 2023 when he comes, this is how it looks. What do you see now? Okay, let's start with the right field is looking kind of okay. Left field? As you can see, the left field has a kind of a temporal defect. It looks as if it's connected to the blind spot, but there is a certain kind of a linearity or a homonymous hemianopic kind of a flavor to it on the top. So better to be suspicious, okay, and think of this as a temporal defect. Do a scan. Here you can see this large pituitary adenoma with suprasellar compression. What I'd like you to notice here is this is the optic nerve there. You see that? The optic nerve is not centered. The tumor has grown asymmetrically and has pushed the optic nerve, which is sliding over the tumor, and there is pressure here over the junction of the right optic nerve and the chiasm, which is where you have the inferonasal peripheral fibers of the fellow eye, your Wildbrand's knee, which is producing this upper temporal defect. Now I'm asking you, as I told in my history, go back and look at that field in 2018. And you can see that there. It's just starting to develop. So we could theoretically have picked it up in 2018, but except we must have thought this is some artifactual thing. Probably if it come 6 months later, a year later, that field defect would have grown and we'd have done the scan earlier rather than 5 years later, that way. Okay, so this is the classic traqueous junctional scotoma. Okay, so in a unilateral optic neuropathy, the neurologically more important field is the field of the contralateral eye. If you have an optic nerve defect in one eye, you're going to get a central scotoma, generalized depression, whatever. You know you're going to get a field defect. How is that eye on the other side with the 6/6 vision? How is its field? And if you see some kind of a temporal defect on that side, be careful there. Okay, which also brings us to our 30-2 tests. So generally across the visual pathway from the front to the back, 30 degrees is good enough. But except for maybe the chiasm, sometimes it's possible to miss these early defects because they start off in the temporal periphery, not in the center. Okay. Okay, these are a little odd. You can see they have a homonymous kind of a flavor because they are both on the left side, but they are not completely hemianopic. There are areas which are spared up and below in that hemifield. Okay, this is a sector. Okay, it's not a quadrant, it's a slice of a cake maybe. So this is a sector. Okay, so this is a sector anopia. Okay, sector anopias, you see defects like this point to LGB. This is the lateral geniculate body. The geniculate body has two different circulations on the MCA and the PCA. So depending on which one gets infarcted, you can get slightly different kinds of sector anopia. You saw one kind of sector anopia now. Sometimes that area can be spared and the opposite areas can be involved as well. Okay, so the message I'm trying to convey here is, if you have a complete homonymous defect on one side like a hemianopia, it's not possible to say where it is, optic tract, LGB, radiations, cortex, anywhere along the line. But if it's incomplete, like you see patterns, then you can say, okay, this is sector anopia, etc. So here you can see that center is spared, but the peripheries of that hemifields are involved. Since it involves 4 areas, we call them a quadruple sector anopia. So this is again LGB lesion. This one is familiar to you. This is a left superior quadrantopia. Okay, and superior quadrantopias means involvement of the Mayer's loop, the inferior fibers in the temporal lobe. On the opposite, this is a temporo-occipital infarct which causes this. On the other way, you can get this. This looks like a very busy, noisy looking field, but focus on the pattern, which is basically here. Okay, this is an inferior quadrantic which is caused by a parietal lobe radiation involvement. Okay, this is a thalamoparietal hematoma of those days. The last lesson I have is always perform confrontation fields. Okay, very important. You can say anyway we're going to do a visual field for the patient. We're going to send him for a field test. You can't do a field test in someone who's got say 3 meters vision. So all the more reason for you, the only way you can assess the field is by confrontation. Use color confrontation if possible also. There's only one other thing I'd like to talk about, which is hemi-neglect, beautifully shown in this video straight from YouTube. You can go and watch it. Let's take a look. Here is this elderly gentleman. I don't know whether the volume is there. So he's saying that he can only see on the right side. Okay. And he cannot see anything from the left side. And his wife also says that, look, from this side, only his vision is there. Okay. So now he's doing a confrontation. As you can see in the right hemifield, he's able to see. In the left one, he's not able to see. Okay. This is a left homonymous hemianopia. But now the examiners moved both his fingers to the seeing area. See, he sees one. Now he sees the right side. Now he sees the left side. Now when both are presented, he sees only the right. See that? He misses the left one. This is hemi-neglect. Okay. And you get that very typically in the parietal lobe lesion. Okay. My last slide. Here is the plan. I said you can have a field defect. Is it unilateral or bilateral? If it's unilateral, think about problems within the eye or that particular optic nerve. If it's a bilateral defect, ask yourself, is it respecting the vertical meridian? If it isn't, it could be retina or optic nerve or maybe the junctional kind of a scotoma. But if it is respecting the vertical meridian, you're dealing with a hemianopia. So ask yourself, is it homonymous or heteronymous? Heteronymous comes in two flavors, bitemporal and binasal, but all of them need imaging as well. Homonymous, if it's complete homonymous hemianopia, as I told you, all we know is it's retrochiasmal on the opposite side. LGB tract, LGB radiations cortex somewhere. But if it is incomplete, then you can get patterns. If it's incongruous, you can get optic tract. If you get sectors, then it's most likely to be lateral geniculate body. And if it's congruous, very congruous, think of the quadrantopias as radiations, and very congruous defects is occipital cortex.